Hi, this is Brian Wood from the University of Washington, and for this National HIV Curriculum mini lecture, I am going to review the latest guidelines for non-occupational post-exposure prophylaxis, also known as nPEP. This is where you can find the guidelines, which were updated in May 2025. The source is at the bottom, and my plan is to review some of the updates and key changes, especially those that will be most relevant to clinical practice. You may or may not know that the original use of nPEP, again, non-occupational post-exposure prophylaxis, to prevent HIV infection was largely based on this study in which macaque monkeys were inoculated intravenously with SIV, which is simian immunodeficiency virus, the equivalent to HIV for macaques. You can see the SIV was given at a very high dose, and the macaques were started on post-exposure prophylaxis at different times from the inoculation of SIV and for different durations. The PEP regimen given here was tenofovir, the NRTI, administered subcutaneously. And on the right, you can see the different groups in the trial. So some were given placebo for 28 days, others tenofovir started 24 hours after the SIV inoculation and given for 3 days. Some started at 24 hours and received tenofovir for 10 days. Others started at 24 hours and received the NRTI for 28 days. Others started at 48 hours and received the medication for 28 days. And finally, started 72 hours after the exposure and received the medication for 28 days. I will show you the key finding here, and I think it's important to note that even though this is an old study and it's an animal model, it really still affects how we prescribe and counsel about and recommend nPEP these days. So you can see persistent SIV infection on the y-axis, and you can see the different arms of the trial, each represented by a bar here. And if you look at the group who had 0 SIV infections after the exposure, you can see that that was the arm that started the post-exposure prophylaxis medication at 24 hours and took the medication for 28 days. So this really served as the basis for why we try to start nPEP early and for why we prescribe 28 days. Now you can obviously see here the comparison was 3 days, 10 days, or 28 days. So that is the comparison we have to go on. We really don't know if 21 days would be sufficient or if 30-something days would be even better, but there were 0 infections with 28 days. And again, this served as the foundation for prescriptions of nPEP and still influences what we do today. This is a table from the guidelines that shows the estimated per act probability of acquiring HIV from a person who was the source of an exposure, assuming that person has HIV. Now, this is based on relatively old evidence. This data is pretty limited. These are only estimates. These estimates assume that the person who was the source of the exposure has HIV. For the sexual transmission estimates, this assumes condomless sex. And these estimates were developed before the era of PrEP, before we learned all that we have about the importance of viral load, and learned that the higher the viral load, the higher the likelihood of transmission. This does not take into account presence of bacterial STIs or other factors. So I would emphasize these are very rough estimates. However, I have had moments in the clinic in which a person presents to discuss PEP. And in the course of that discussion, I find it helpful to bring up this table and show them and talk through the relative risk based on each of these estimates. For example, if someone comes to talk about PEP and we're discussing receptive oral intercourse or insert of oral intercourse, it can be helpful, I think, to show this table and counsel about how low the risk of transmission is. On the other hand, if someone comes to discuss PEP due to condomless receptive anal intercourse with a partner either known to have HIV or whose HIV status is not known, or if they come to discuss risk from needle sharing during injection drug use, I think that sometimes discussing the relative risk and showing this data can be helpful. I don't show it to everyone who comes to me to discuss PEP, but I have had moments where I bring it up and show it as part of my counseling in clinic. This latest version of the guidelines includes updated flow charts that outline some really important considerations for counseling individuals about possible need of nPEP. And there are some key updates as compared to earlier iterations of the guidelines. So I'm going to take a couple minutes to talk through these. So starting with this flowchart for possible sexual exposure. So this could be someone who comes to you to discuss nPEP after sexual assault or condom breakage or other possible sexual exposure. There are a few key clinical considerations. So the first, as you can see, is the time since exposure. If we follow it to the far right, if more than 72 hours have elapsed since the exposure, in general, nPEP is not recommended. There may be extreme circumstances in which I would prescribe nPEP, but they would be very atypical, and I would include a lot of counseling that it is not guidelines-based and we do not know the efficacy, and there may be lower efficacy of nPEP if started after 72 hours. So I just want to emphasize that if it is after 72 hours since the exposure, nPEP is generally not recommended. Now, if we go to the left instead, if less than or equal to 72 hours has passed since the exposure, then nPEP should be considered. Now, based on the prior data I showed you from the macaque model, I think that starting even sooner than 72 hours is probably ideal. For example, starting within 24 hours. But that often is not realistic, and I agree with this recommendation to consider nPEP if less than or equal to 72 hours have passed. So let's follow from the less than 72 hours since exposure, first to the far left. If the exposure was oral genital sexual contact without a condom, nPEP is not routinely recommended because the risk of HIV transmission is so low. So there may be exceptions to that rule with other factors to consider, but in general, nPEP would not be recommended. On the other hand, let's follow that row to the far right. If an intact condom was used, nPEP also is not routinely recommended because of the overall high efficacy of condoms. Again, there may be exceptions, but I think it's important to note that in general, nPEP would not be recommended in that scenario. Now let's go to the middle part of that row. If the person you are seeing has had anal or vaginal intercourse without a condom, there are several key considerations. I'm going to go from that box to the right blue box, the blue box on the right side. This is a key update. If the person has had possible exposure to HIV, but they have been prescribed HIV PrEP, that's pre-exposure prophylaxis, and they've been taking it or receiving it as recommended, then nPEP is not generally recommended. I'm going to say this slightly different. If a person is taking HIV PrEP, and that could be oral PrEP or receiving cabotegravir or lenacapavir as PrEP, and they have been taking it with good adherence. They've been showing up for all their injections on time. Basically, what this means is that the expected efficacy of PrEP is so high that adding more antiretrovirals for nPEP will not add clinically relevant benefit. So in that situation, we would simply encourage the individual to continue with PrEP. Really, that is the reason for PrEP. And PrEP is so efficacious that even with a possible exposure, we would not expand the regimen to give nPEP. There may be other considerations, testing for bacterial STIs, testing for hepatitis C virus. There may be other things to recommend, but in general, nPEP would not be recommended. Okay, now to the blue box that is on the left. If the person with the possible exposure has not been prescribed HIV PrEP or is not taking PrEP as recommended, they have been missing doses or have stopped it, or again, if they've not been prescribed PrEP at any point, then the next consideration in the dark gray boxes is the person who was the source of the possible exposure known to have HIV, or is there no way to test and find out, and is the source of unknown HIV status? So let's start at that dark gray box on the left. So again, if the person with the possible exposure has not been taking HIV PrEP, and the person who was the source of exposure has unknown HIV status, then nPEP can be considered and prescribed on a case-by-case basis, basically meaning we would counsel the person with the possible exposure about pros and cons, about the risk, and make a decision with them about nPEP. Going to the right dark gray box, if the person who was the source of the HIV exposure is known to have HIV, then let's follow that down to the gray box below that on the right. If that person who was the source of the possible HIV exposure is known to have HIV, however, they have known sustained viral suppression, for example, with adherence to ART, then nPEP is not routinely recommended. And that is another key update to these guidelines and is based on all that we have learned about how unlikely HIV transmission is if the person with HIV has a suppressed viral load. So again, if a person has a possible exposure to HIV, but the person who was the source of the possible exposure has HIV and has sustained viral suppression, nPEP is not routinely recommended. I highlight that again because it is a very key update from past iterations of the guidelines. Now, the gray box on the lower left, if the person who was the source of the exposure has HIV with known viremia, or you do not know their viral load, then nPEP is recommended. Finally, the purple box at the bottom is a reminder that for anyone who is prescribed nPEP for possible sexual exposure, they may benefit from HIV pre-exposure prophylaxis, and it is important to inform them about that option. This is the flowchart for possible injection drug exposure to HIV. You can see that similar to with sexual exposures, the first decision point is time since the possible exposure. And then following down from less than or equal to 72 hours, let's start on the right. If the person who was the source of the possible HIV exposure has unknown HIV status, then nPEP can be considered and prescribed on a case-by-case basis. And then on the left, if the person who was the source of the possible exposure has sustained viral suppression, here, and I think this is key, nPEP can be considered on a case-by-case determination. Whereas with sexual exposures, we have learned a lot about how incredibly unlikely it would be to transmit HIV in the setting of a suppressed viral load. We just don't have the same data with injection exposures or with possible injection transmissions. So here, I think counseling could be done and a decision about nPEP could be made with shared decision making with the person with the possible exposure. And then on the far left, if the person who was the source of the possible exposure has HIV with known viremia or unknown viral load, then nPEP is recommended. And on the last flow chart that is provided, these are less common possible exposures that come up, but I certainly have seen them come up in clinical practice. So again, decision making based on time since exposure. On the far left, any blood or infectious bodily fluid splashes to non-intact skin or mucous membranes can lead to nPEP prescription, but on a case-by-case determination. These are likely low-risk exposures, but if bloody fluids splash onto non-intact skin or, for example, into the eyes or mucous membranes of the mouth, in theory, there could be a risk of transmission. Now, remember that bodily fluids like urine, stool, and others do not transmit HIV unless they are bloody. So that is an important consideration. Again, I think the overall risk is low, but nPEP could be considered. If a person has an injury from discarded needles in the community, nPEP is not recommended except for exceptional circumstances. For example, freshly bloody discarded needles. I have had this situation come up in clinical practice. Now, for other possible exposures that include kissing, mutual masturbation, exposure to bodily fluids not associated with HIV, so again, tears, sweat, urine, nasal secretion, saliva, others that are non-bloody, nPEP is not routinely recommended. That is similar for human bites, except in very exceptional circumstances in which, for some reason, there may have been transmission of blood. And if other exposures come up that are not on this list, it is worth talking to an expert. This is an important table available in the Guidelines document. This table outlines the recommended baseline and follow-up laboratory testing, and there have been a couple of really key updates since the last version. So I'm going to talk through this a bit. I will highlight what the footnotes say in a few of these places, and I would encourage you to take a look because the footnotes give a lot of details. And I will also try to underscore what is changed, what is updated and new, and especially how it might affect clinical practice. So first in the blue column, these are the recommended baseline laboratory tests for the individual who was the source of the possible HIV exposure. Obviously, this assumes the source person is known, is available, and is willing to come in for testing. In my experience, that is not a common scenario, but I have had it come up. I have had that happen in my practice. So this is worth knowing. So if the individual who was the source can come in for laboratory testing, it is recommended to screen for HIV. Obviously, that is really critical for making decisions about PEP. If you can confirm the source individual does not have HIV, then the individual who was exposed does not need post-exposure prophylaxis. So if you're screening for HIV, you can make decisions based on a rapid point-of-care test if that is available to you, but a laboratory-based antigen antibody test should also be performed for confirmation. The diagnostic NAT, which is an HIV RNA, is not indicated very often. The footnote in the guidelines is only if the individual has received injectable antiretrovirals within the past 6 months. I really have not seen that come up in practice and don't anticipate it will very often. Hepatitis B serologies, on the other hand, are always indicated. That can be very informative in terms of the person who was exposed and their risk of acquiring hepatitis B. For Hep C testing, for the person who was the source of exposure, The guidelines favor NAT testing, that's RNA, HCV NAT testing, because the antibody test may be positive even if someone cleared or was treated and had successful treatment for Hep C in the past. So the RNA is preferred because it confirms active infection that is a risk of transmission. The footnote is to cite that if RNA NAT is not available, then clinicians should order antibody testing as the alternative. Syphilis serology, other bacterial STI testing, and pregnancy test also recommended if clinically this is relevant, if there are risks of transmitted STIs. The syphilis serology footnote is simply to say that clinicians should decide if this is relevant or not. The gonorrhea and chlamydia testing notes are to remind clinicians that all sites of potential exposure, oropharynx, urethral, and rectal sites should be tested if indicated, and a pregnancy test is recommended for all women of childbearing potential. Turning then to the columns for the individual who may have been exposed to HIV, you can see the recommended baseline testing, and a lot of the footnotes are similar. The additions are a serum creatinine and AST and ALT testing. There also is a slight difference here in that a Hep C antibody is reasonable and NAT not generally indicated. Now, I want to outline a couple of things that are changed or updated, and I have summarized these on the right hand of the slide as well. So, in general, the person exposed to HIV should have follow-up testing 4 to 6 weeks after the exposure and 12 weeks after the exposure. However, these guidelines say it is okay to skip the 4 to 6 week HIV testing mark if the nPEP was started within 24 hours of the exposure, the individual has not missed any doses, and they are not transitioning to HIV pre-exposure prophylaxis. So to reiterate that, if an individual has come in for care within 24 hours and started nPEP within 24 hours of the exposure, they have taken it as prescribed, and they don't plan to go right from PEP to PrEP at the end of their 28 days of PEP, then you can forego this HIV testing that is at 4 to 6 weeks. If a person has started PEP between the 24-hour and 72-hour mark, if they may have missed some doses, if they are transitioning to PrEP right after their 28 days of PEP, then this 4 to 6 week testing is recommended. The other point here, and this is what I've circled in the row about HIV diagnostic NAT, is now in the guidelines, at times that HIV testing is performed for monitoring the person exposed to HIV, in addition to an antigen antibody test, a NAT or RNA test is recommended. So let's say a person has presented to care within 24 hours of an exposure, they take nPEP as recommended, then their only follow-up test would be at 12 weeks. Again, you can skip the 4 to 6 week testing. So their follow-up testing will be at 12 weeks and should be an antigen antibody and NAT test. On the other hand, if someone presents later than 24 hours but still within the window to start PEP, and they do start PEP and take it, or maybe they had some missed doses, or they are at risk for recurrent exposures and are a good candidate for PrEP and are motivated to take PrEP, then a test at 4 to 6 weeks, and if they're going right to PrEP, I might do that on the sooner end of that window, then HIV testing is indicated, and importantly, it should be an antigen antibody test and diagnostic NAT or RNA test. So those are key updates and differences from prior versions of the guidelines. And then you can see here 6 months after exposure, for the person who may have been exposed, you can see the recommendations for Hep B screening and Hep C screening if those are relevant, and I'll talk a bit more about those. Another key update to these guidelines has to do with which medications are prescribed for nPEP. So here are the preferred and alternative regimens for adults and adolescents. So these are individuals age 12 or above who have creatinine clearance greater than or equal to 50 and are not pregnant. These are much more in line with the what to start recommendations for people with HIV. So these are all integrase strand transfer inhibitor anchored regimens. So they are all integrase inhibitors with 2 NRTIs. The first is bictegravir, tenofovir alafenamide, emtricitabine. You will hear that as BIC-TAF FTC or similar variations. The other preferred option is dolutegravir plus either tenofovir alafenamide or tenofovir DF, which is combined with emtricitabine or lamivudine. So this would be dolutegravir with TAF FTC or dolutegravir with TDF FTC or TDF 3TC. The alternative is a boosted protease inhibitor with 2 NRTIs. The boosted protease inhibitor would generally be boosted darunavir. So overall key point here, the preferred regimens now are an integrase inhibitor like bictegravir or dolutegravir with 2 tenofovir-based NRTIs. The hepatitis B post-exposure prophylaxis guidance really hinges on the hepatitis B status of the source person if it is known, and the hepatitis B status of the person with the possible exposure. And it really depends on whether the person who was exposed has had vaccine in the past, either a complete series or a partial series, and whether it is known or unknown if they successfully responded to that series. And the potential measures for hepatitis B PEP include vaccine with or without hepatitis B immune globulin, and I won't go into more detail about this, but will emphasize that the hepatitis B serology panel and vaccine history for the person exposed is really critical, and the hepatitis B antigen status for the individual who was the source is also really informative if that is available. In terms of hepatitis C post-exposure prophylaxis, there certainly is Hep C transmission risk, either with sexual contact or with sharing the injection works or needles for individuals who are injecting drugs. However, there is no current recommendation for a Hep C direct-acting antiviral for post-exposure prophylaxis. Part of that is that luckily the transmission risk is relatively low, and the other part of it is we simply need more research and data for the safety and efficacy of Hep C antivirals in this setting. So what is recommended is to assess the person who was exposed for Hep C antibody. If it is positive, then reflex to a nucleic acid amplification test, that's the RNA test. If the source person is available, as I mentioned, it would be ideal to test that individual for a NAT or RNA level to confirm active infection and to assess the risk of hepatitis C transmission. But again, there is no recommendation to prescribe Hep C therapy, at least at this time, to prevent possible transmission. So if a person is at risk of acquiring hepatitis C, these are the follow-up tests that are recommended. There certainly are other really important considerations with nPEP that I won't be able to discuss in detail with this talk, but I will emphasize that for sexual assault victims, having support services are really, really critical. Talking to individuals about the transition from nPEP to PrEP is also important if the individual may have ongoing risk for HIV exposures in the future. There is a different concept called PIP or PEP in pocket, which is, as opposed to PrEP, in which a person takes or receives an HIV medication, so it's on board at the time of exposures. PEP in pocket is an alternative in which a person hangs on to a prescription for PEP and then in the future fills it, or if it's already filled, then takes PEP after an exposure. This is not something I have prescribed in practice, but I know it's been done. I know it's an option for individuals who, for whatever reason, don't want to do PrEP but may have future exposures or can't access PrEP. So it is an alternative option to be aware of. And then for anyone with ongoing sexual risk for bacterial STIs, talking about doxy-PEP is also important. In summary, the latest CDC nPEP recommendations emphasize the importance of an early nPEP start. There are updates to language around transmission risk with undetectable viral load, and that updated language and the updated flow sheets definitely will affect clinical decision making. The recommended regimens are now much more in line with HIV treatment best practices. The guidelines do include recommendations for ART options in the setting of severe renal dysfunction, hepatic dysfunction, pregnancy or breastfeeding, and I did not talk about that. So please see the guidelines and please consult an expert if the need for nPEP comes up and any of those situations are relevant. And then finally, there is a new recommendation for HIV NAT testing for the individual who was exposed. The NAT test should be added to the antigen antibody test. However, in certain circumstances, like a very early nPEP start and really good adherence to the meds and not planning to transition to PrEP, it is reasonable to skip the 4 to 6 week HIV check. And with that, I will wrap up this National HIV Curriculum mini lecture. Thank you for watching.